Hello and welcome to our recap session. So we are going to talk about again how to read an abdominal X-ray, which is very important. Then we show you more fluoroscopy study and what is a fluoroscopy and the main complaints about fluoroscopy. And last, we talk about appendicitis, specific appendicitis in ultrasound. You have to remember appendicitis, the diagnosis of appendicitis is mainly clinical. It's mainly clinical. So when you have your impression diagnosis, you send for appendicitis depending on where you are. You have any ultrasound available, of course you have to request for ultrasound just to confirm your diagnosis. But you have to remember sometimes the ultrasound can be negative, and the patient can has this acute appendicitis. Sometimes the appendicitis is retrocecal, which is sometimes very difficult to see on the scan. The other thing you have to know is a complication of appendicitis, which is also you have to request ultrasound on that regard. But you have to remember the diagnosis of appendicitis is mainly clinical. Okay, so based on that, let's start.
Approach an abdominal X-ray. So our objective will be to introduce you to normal abdominal X-ray, a couple of normal X-rays, and then recognize some important or common abnormalities. So if you get any abdominal or chest X-rays or any radiology film, we normally notice the age, sex of the patient, and then in X-ray abdomen or chest, whether it's supine or erect film, and then focus on the luminal and extraluminal gas pattern. So, and additional opacities such as calcification or artifacts. Coming to finally soft tissues and bones, and then you summarize the findings, normal and abnormal.
Okay, so the age and the sex and supine erect are going to be written on the film somewhere, aren't they? Or
usually they will be. There will be some indication of, or it will be given in your history that this is patient's age, this is sex. Supine erect will be written on the film. So
okay, thanks.
The main thing on abdominal X-ray out of these, the list of these things, is luminal gas pattern, extraluminal gas, calcification, and additional opacities or artifacts. So we like talking about A, B, C.
Easy enough to remember.
So A is for additional opacities, right. B for bowel gas pattern or extraluminal bowel gas pattern or extraluminal gas pattern. C is for calcification. So easy to remember, and then we will put into practice. So here we go. We have got a abdominal X-ray, and if you look on this, so here is so putting into practice A, B, C. Any additional opacities here? We cannot see anything additionally. So let me just move the mouse. So that's bowel gas, B for bowel gas. So this is the peripheral bowel gas. So if you look from your anatomy, you would know it's peripheral, looks like large bowel. So ascending colon, hepatic flexure, transverse, splenic, and then descending colon, and somewhere here will.
That's very nice. I mean, you say it looks like large bowel. What is it about those gas appearances, apart from being peripheral, that makes it look like large bowel?
Yeah, there are certain other things like obviously location, so it's peripheral.
Yeah.
Then usually large bowel contains gas, which is not the same thing for small bowel. Small bowel usually we don't see much gas.
Okay.
And then is the presence or absence of the markings. So in large bowel we see hostra, which are incomplete, widely placed rings like these ones, not rings but incomplete lines. So these are hostra, so one here, one there, and here. In a small bowel you see more, you normally don't see, but if it's dilated you see like kids play with slingy. So
that slinky,
slinky. So that
you get lines all the way across. You see that in small bowel obstruction here, but that's a very nice haustral gas pattern there.
That's correct.
Yeah.
So that's the large bowel. So we've seen bowel gas pattern, no obvious extraluminal gas here. Most of the time you'll be looking for gas patterns in the liver, i.e. biliary gas, portal gas, or outside if there was abscess or anything. But plain film, there is only so much you can tell.
Yeah.
So that's the normal abdominal X-ray. Moving on to next. This is another abdominal X-ray, but here if you remember the last one, not much gas in the ascending or transverse colon. In fact, if anything, it looks more mottled, and this is just fecal residue, and again very much normal. So that's where the colon is, and you can see some fecal residue all the way.
Okay, so this isn't constipation, is it? This is constipation is a symptom, isn't it?
Yeah. So and that's why we don't do abdominal X-ray for diagnosing constipation or anything.
Yeah.
And this is the rectal gas here.
Yeah.
So again, very much normal, and you can see.
And seeing this amount of fecal loading is quite normal, isn't it?
Yes.
Yeah.
Yes.
Okay.
So that's again normal.
Yeah.
No additional
So
opacities.
But the important thing, it looks a bit different from the other normal one.
That's correct.
Yeah. Okay.
And moving on to the next one. And here if you put additional opacity, so you can straight away see something in the right upper quadrant here.
Oh, yeah.
Looks like some clips, very nicely demonstrated. And these are cholecystectomy clip from previous surgery. And also if you notice, you've got two opacities, linear opacities here. These are just artifacts from the wire in the bra.
Okay.
And then coming to B for bowel gas. Normal bowel gas pattern again. This is some gas in the ascending and descending colon here.
Yeah.
Some little in the rectum here, but otherwise, again, very much normal pattern.
Okay.
Moving on to next film here. If you remember from the just seconds ago, we were talking about the complete rings of small bowel.
Oh, yeah.
So now and then if you see a little bit of a small bowel distension, that's not abnormal, that's within normal limits. And here you can see, compared to the hostile pattern, incomplete lines, here is complete line going through and through the bowel. And that's the volvuli conniventis or plica semilunaris. And that's a small bowel hallmark. Otherwise, the bowel gas pattern, again, this is normal pattern. It's not obstructed, not distended. And in the additional opacities or calcification, if you look at these areas, these are just calcification in the costal cartilages.
Oh, yeah, yeah.
And
yeah,
again, it's
yeah,
normal.
and they're entirely normal. And did they get more common as you get older?
That's right, yeah.
Yeah. Okay, so another normal one. So
we have done the range of, couple of normal abdominal X-rays, and we will now see some pathologies. So here we have got an abdominal X-ray, patient presented with abdominal pain, and as a routine you do abdominal film. We did one, and if you look here, there are some closely packed calcific densities projected over the right upper quadrant, and there is one small separate opacity. So this looks like that someone has packed small small stones or gravel in a very close sac, and the sac-like structure in this area got to be
is it gallbladder? Yeah,
that's correct.
Great.
So
I'm a radiologist.
but it doesn't tell you more than that whether the gallbladder is abnormal, because lots of people on the street walking with gallstones have got no problems.
Yeah.
So in itself,
that coupled with the symptoms.
Yes.
So the other important thing for a radiologist is that you write the request form for as much detail about the clinical thing as possible. I know you guys get quite upset about that.
That's
sometimes.
right. Clinical history is very important for us to interpret the findings on the imaging.
Yeah.
So that might be in the cystic duct or in the CBD, and maybe this gallbladder is thickened in correct clinical setting, and you need to take it further by doing ultrasound or CT scan.
Having said that, the gallstones are only opaque in about 10% of cases. Is that correct?
I think it's about that's right, 10 to 15%.
Okay, yeah. So ultrasound's a better way of looking at gallstones, but your point's made about the opacities. Absolutely.
That's right. And again, this is not abnormal in itself just to spot this, but in the correct clinical setting and findings, it will be significant.
Yeah.
And bowel gas pattern again looks normal. You can see very little in the large and small bowel, so that's normal.
Okay.
Then that's just showing you the gallstone.
C for calcification,
Yeah, and the next picture here we have got is another, so A, B, C, additional opacities. So if you look at these bra wires, these are artifacts, and there is a laminated opacity in the right upper quadrant. This is again gallstone, cholesterol gallstone, usually solitary, laminated, big one here.
They're like big marbles, aren't they? Cholesterol stones.
That's right. Yeah. So that's our calcification.
I find that harder to spot. I'm glad there's a big arrow there showing us where it is.
It is difficult, but if you know what you're looking for, you can see. But again, I haven't seen that. Doesn't matter that lots of people will have it. If the patient is symptomatic, then it becomes more important.
Okay.
So that's just the zoomed in view to show you the calcification here. And then this is just the soft tissue, looks normal. And this is additional opacity, as I say, artifact. So, and again, this patient, if he was symptomatic, will do ultrasound to take it further.
Yeah.
That's the ultrasound on that patient.
Okay, well, the same patient?
Exactly, same patient. So you can see nicely distended, thin-walled gallbladder here. That's the big calculus which we saw. And how you know it's a stone, because sound waves travel nicely through the fluid, and if there is calcification or anything, very little sound waves or no sound waves go behind it. So you get shadowing here, which is called acoustic shadowing.
So the probe's at the top of the picture, that's shining through the skin
surface. That's
and
the
then
probe.
the picture's made up of things that bounce back.
Some absorb, some gets bounced back by the different layers of tissues, and then is picked up by the receiver in the transducer. And with the help of computer, obviously, we get the images.
And then, so the dark shadow on the right-hand side, that's the gallbladder filled with
fluid,
bile
in the gallbladder.
And then the sound waves bounce back off the front of the big cholesterol stone. And they don't go through the cholesterol stone, so that's where you get the shadow behind it.
And if you look at this fluid, it enhances the flow of sound waves through it, so you get brightness behind it. And that's called acoustic enhancement. So shadowing and enhancement. And that's how you differentiate cystic and solid structures or calcific densities.
Very, very interesting.
So gallbladder, and that's the calculus. Stone.
Very good.
There is this picture again, abdominal X-ray. So if you look here, bowel gas pattern again, very much normal. And this is a bowel gas shadow here, and well-defined opacity. Most of the time, if you spot any well-defined opacity, think about man-made stuff.
Right. That's pretty circular then, yeah?
Very nice, yeah. So that's a tablet in the stomach.
Right.
And that's the stomach shadow, gas shadow.
Oh, yeah.
So A and B, bowel gas and additional opacity.
Okay. Right. Okay. Well, thank you for that. So you've given us a structure for how to look at things and show some views of normal. Could you just summarise what everyone needs to take home about normal abdominal X-rays?
Yeah, abdominal X-rays or any X-rays. First of all, we have to look at lots of normals to familiarise what is normal, what is the spectrum of normal, and then I just gave you the A, B, C because people like doing A, B, C. So if you can't remember anything, then try to fit things in A, B, C.
And that's just one way of looking at it. It's an easy way to remember.
You have your own way, and people have their own way. But that's just to help if you can't remember anything. Then.
And A stands for?
So A is for additional opacities.
B?
Bowel gas pattern or extraluminal gas pattern, and C is for calcification.
Okay, well, thank you very much, Dr. Singh.
My pleasure.
That's very clear. Thank you very much indeed.
Cheers.
Is an X-ray examination of the beginning of the digestive system. When the exam is limited to the throat and esophagus only, we call it a barium swallow. This is a schematic drawing highlighting the various parts of the upper GI tract we can evaluate with this test. As I said before, we image the mouth and throat, esophagus, and stomach. Here's an enlarged view of the stomach and the first part of the small intestine, which is also known as the duodenum, which we can also evaluate on an upper GI exam. You may wonder how best to prepare for this test. To ensure the best possible image quality, your stomach must be empty of food. You will likely be asked not to eat or drink anything, including any medications taken by mouth, especially antacids. Also, please refrain from chewing gum and smoking after midnight on the day of the examination. Upper GI exams use a special form of X-ray called fluoroscopy. Fluoroscopy provides live radiographic images while switched on. The radiologist, shown here sitting behind a protective screen, uses the equipment to watch the passage of contrast through the upper GI tract and to observe internal organs in motion. Before or during the exam, patients are asked to drink an oral contrast liquid, most commonly containing a substance called barium. An X-ray camera can see barium inside a patient from the outside. After drinking it, barium sticks to the inner surface of your internal organs like paint to a wall and makes them visible to the X-ray eye. The radiologist can now view and assess anatomy and function of the digestive tract. Some patients are also given baking soda crystals, which produce some gas inside the patient, distending the upper GI tract. Using both contrast and the gas helps to see the lining of the GI tract better. Your doctor may ask you to undergo an upper GI exam if you have symptoms such as difficulty swallowing, chest and abdominal pain, reflux, which is a backward flow of partially digested food and digestive juices, and other symptoms. An upper GI exam helps to evaluate digestive function and can diagnose many diseases of the upper GI tract. Here are some examples: swallowing disorders, inflammation of the esophagus, stomach and duodenum, hiatal hernias, ulcers, tumors, and other things. The following slides contain some example images from upper GI exams, showing some of the conditions we can see on these exams. This is an image of a patient's throat, seen from the side. For orientation, the spine is labeled. Barium, seen here in black, is passing through the throat, shown by the green arrow, and some of the barium gets caught in an abnormal outpouching of the hind wall of the throat, called a Zenker diverticulum. This second image shows that most of the barium has passed into the esophagus, while some got stuck in the Zenker diverticulum. In patients with this condition, food can get stuck in this little pouch and cause bad breath or accidentally spill out into the neighborhood, such as the breathing tube. Here you see a short loop of a movie of a patient whose esophagus is giving trouble. The image shows a view into the patient from the side. The patient is actually swallowing barium contrast. The black column in this image is barium passing through the esophagus as the camera is filming it. The esophagus, which is basically a tube mostly made up of muscle, is first moving the barium downward just fine, but then, at some point, goes into a spasm, which looks like a corkscrew, and makes it difficult for more barium to pass downward. When the spasm occurs, the patient has a sensation that food, or in this case barium, is getting stuck. This is a radiographic picture of a normal stomach. The stomach lining is coated with barium. The stomach is filled with gas from baking soda crystals. You can see the body, which is the main part of the stomach, marked by the letter B, and the exit of the stomach, the so-called antrum, marked by the letter A. Little black arrowheads point to normal folds of the lining of the stomach. The first part of the stomach, called the fundus, marked by the letter F, is filled here with dense white barium. This is an image of a patient with erosive gastritis. This condition can be caused by taking common over-the-counter anti-inflammatory painkiller type pills. Chronic inflammation of the stomach lining and too much acid in the stomach can result in the development of many little ulcers, shown here on images from an upper GI exam. The small image at the bottom shows the many little ulcers in the stomach. Barium, which looks white on these images, pools in the little ulcer craters, which are shallow grooves in the lining of the stomach. The dark ring around each little white barium puddle on this image is caused by swelling of the inflamed stomach lining surrounding the ulcer crater. This patient has developed a tight blockage in the duodenum. The duodenum normally looks like a tube and is the first part of the human small bowel. In this patient, the blockage causes barium to back up into the stomach. The reason is a cancer of the duodenum, marked here with a red C, which wraps around the duodenum, squeezing it tightly, which is illustrated by the green arrows. If the cancer has not yet spread, this patient may need an operation to remove the cancer and restore passage for food and liquid.
In this examination, both barium sulfate and air are administered through the rectum. When the exam is limited to barium or water-soluble contrast only, the exam is called a single contrast study. This educational video focuses on the double contrast exam. Here's a list of common indications you're probably already familiar with. This exam has potential in helping to diagnose pretty much any disease that's intrinsically or extrinsically affecting the colon. Make sure to document any pertinent history or patient symptoms. Changes in bowel habits may include hematochezia, diarrhea, or constipation. You can come across other pertinent history, such as previous colon polyps or a family history of diseases involving the colon. The possible contraindications of the exam include, but are not limited to, unexplained pneumoperitoneum and toxic position on an IV pole to allow the contrast to flow. The patient is usually in somewhat of a left lateral position after the rectal tip is placed. I like to take a quick look at the tip in position, especially if a retention cuff is used, in order to ensure it's in the proper position and the cuff isn't over or under inflated. Bring the image intensifier or flat panel detector close to your patient, since this reduces the dose to the patient, to you, and to the technologist. The patient is traditionally placed in the prone position to administer the barium, although in some indications, the exam should begin in the left lateral position. I like to control the barium flow by unpinching the tube with my right hand. I can slow or stop the barium by pinching the tube. At the same time, I'm able to watch the monitor and control the image intensifier with my left hand. The tube is only opened partially because a rapid distension of the rectum will increase the patient's urge to defecate. My foot intermittently depresses the pedal to watch the flow of barium. In the filling phase, barium should be intermittently watched until it reaches the mid-transverse colon. In general, turning the patient to the left anterior oblique or left side down position moves barium into the proximal sigmoid colon, the descending colon, and the splenic flexure. The barium will pass from the descending colon into the splenic flexure and into the transverse colon with ease in most patients. But you can place the patient in a slight Trendelenburg position if the barium isn't moving into this area. Once a full column of barium reaches the apex of the splenic flexure, turning the patient to the prone position will move the barium into the middle of the transverse colon. Use fluoroscopy intermittently and briefly during this filling phase, but carefully analyze the contour of the colon and look for any abnormalities or defects in the barium pool. If an abnormality is seen while barium is filling the colon, take a spot radiograph. Once barium reaches the middle of the transverse colon, the enema bag is gently lowered to the floor and the rectum is drained by gravity. Make sure you don't clear the entire rectosigmoid colon of barium, because we need enough barium within the colon to coat the entire mucosa and also fill the ascending colon. The small amount is cleared from the rectum to make sure there aren't pools of barium that might obscure lesions. The bag is then clamped, and I tell the patient I'll put some air in the colon to complete this portion of the exam. The air is pumped from either room air, or some departments use carbon dioxide. Make sure that you do this slowly, otherwise the patient experiences severe discomfort and it might incite rectosigmoid spasm. I like to instill 2 to 3 puffs with intermittent fluoroscopic pulses, position the patient, then again instill 2 to 3 puffs. And I keep doing so until the colon is properly coated and distended. During this point of the exam, you need to be flexible yet compulsive. Spot images are taken of the rectum, sigmoid colon, hepatic and splenic flexures, and cecum. But the order doesn't matter so much as long as each loop of colon has adequate barium coating and distension and is demonstrated with as little superimposition or overlap as possible. I try to make sure I take a couple good double contrast images of the sigmoid colon, usually with the patient supine or in a slight supine oblique, before the barium reaches the cecum, since reflux through the ileocecal valve could cause superimposition of the distal ileum on your sigmoid spot images. Continue turning the patient and intermittently and slowly instilling air to make sure the colon is coated and is being distended. I'm scanning the entire colon intermittently at this point. If I see any suspicions or abnormalities, I may further investigate by turning the patient under fluoro, and I may mag to obtain a good spot image. Then unmag to continue the exam. With the patient in a supine position, I'll ask them to turn on their right side facing me to move the barium into the proximal hepatic flexure, then lie on their back so the barium flows into the ascending colon. The patient may be asked to again face down in a prone position, then turn back to a supine position to achieve adequate coating. Remember, barium is much heavier than air and will fill any dependent space. If the barium isn't moving into the ascending colon and cecum with the patient on their right side or the table tilted, it's probably because there's not a large enough volume of barium. Whenever placing the patient in a lateral position, check out the proximal rectum to possibly take a good air contrast image of a lateral rectum or open up overlapping loops of the sigmoid colon. The table can be tilted upright to clear the barium pool and allow the flexures and transverse colon to distend. I usually place my hand on the patient's shoulder and ask them to steady their feet while I slowly raise the table to take good air contrast spot images of the flexures and transverse colon. You can usually get a nice image of the hepatic flexure with their right side lifted up in a left posterior oblique position. While they're in this position, bring the image intensifier down to look at the ascending colon. You may get a nice double contrast image of the hepatic flexure and distal ascending colon. To see the splenic flexure, oblique your patient with their right side down and the left side up in a right posterior oblique position. I usually bring the image intensifier down again to take a look at the ascending, proximal, and middle sections of the descending and the sigmoid colon to assess anatomy and take spot images. Once you have good images of the patient in the upright position, bring the table back to horizontal and do a quick overall scan in unmag mode. You may get a good image of the proximal ascending colon or the inferior portion of the transverse colon. At this point, if contrast has refluxed into the appendix and terminal ileum, take an image. If there's too much contrast in the cecum, you can tilt the table slightly Trendelenburg and roll the patient to their right so the barium moves to the ascending colon and air fills the cecum. Take at least 2 spot images of the air-filled cecum, preferably in a supine and oblique position. If the barium hasn't reached the appendix or terminal ileum, a compression paddle may be used to push barium into this area. A compression paddle may also be used to separate loops of bowel. Overhead images are taken by the technologist after the fluoroscopic portion of the study is completed. These overheads help piece together the spot images and provide the overall big picture of the examination with minimized magnification.